The purpose of this podcast is simple. We want you to get to know your doctor before meeting them in person, because you're making a life-changing decision and time is scarce. The more you can learn about who your doctor is before you meet them, the better that first meeting will be. There's no substitute for an in-person appointment, but we hope this comes close. I'm your host, Eva Shea, and you're listening to Meet the Doctor. Welcome back to Meet the Doctor. My guest today is dermatologic surgeon Ron Shelton, who is in practice in New York City, and he's an expert or has deep expertise in lasers. Welcome to the podcast.
Thank you, Eva. It's a pleasure to be here.
Thank you for taking time on a Saturday to come sit in a dark room with me. It's a beautiful day.
It is a beautiful day, finally, but it's very nice to be here.
Now, are you a longtime New Yorker? Before you were even a doctor, were you here?
I am. I was born in New York City, in Manhattan. Mm-hmm.
So I bet you probably couldn't imagine living anywhere else but here.
Well, I have, and it would be very interesting to live in other areas. I've lived in San Francisco, in Los Angeles, in San Antonio, in Virginia, all for training as well as serving the U.S. Air Force as a physician. And many of the places that I lived, I really enjoyed. But once we decided to bring up family, it was nice to come back to home and be with our families.
You said Air Force in San Antonio, almost in the same sentences. Are those two connected? Is that why you were in San Antonio?
I was, yes.
Yeah. So you were stationed at the base there?
Correct.
How long were you there?
San Antonio was 3 years, and Virginia 2. And Los Angeles, 2.
So how long were you in the Air Force?
7 years.
When you were at the beginning of your career?
It involved a scholarship from medical school.
Mm-hmm.
I didn't want my parents to be feeling like they had to watch their expenses. And 3 years was residency while I was in the Air Force. Yes.
What is dermatology like in the Air Force?
The same as the civilian sector. I was very fortunate where I was because we had a superb faculty. We had 5 hours of homework per se each evening. And, some of our faculty went on to Harvard. One of my passions is Mohs surgery. I had the fortune of studying under Dr. Stuart Salche, one of the nation's best Mohs surgeons. Unfortunately, he's passed away recently. And I was able to have my office, an exam room, for 3 years and saw the same patients, unlike many hospital programs in the civilian sector where residents are forced to go to multiple different hospitals through the week. Any surgery I did, those patients were coming back to me for follow-up. So I really got a very good education as to how wounds heal, what complications look like, and I was able to help my patients through it rather than having a colleague help them. And I found that very beneficial throughout my entire career.
I'm a little surprised that that's not the normal way that doctors are trained. And I can see how that would be an advantage.
Yeah. And the other thing with the Air Force is, you get to treat the active duty. So the age range is, from the 20s until 70s, but you treat their dependents and the retirees. And there's a very big pool of retirees in San Antonio. So there was nothing we didn't see. We had an incredible burn center on the Army post where I actually learned dermatology.
And the patients were all either in the military or related to someone in the military?
Yes.
It's a little bit curious when you say there were lots of burn patients, but were they being burned at work or just by accident?
No. These were trauma cases. San Antonio had at Brooke Army Medical Center, a very big burn center. So there was a young boy in a field struck by lightning, and I heard it on the radio. And that morning at 5, I, before work, went to see him and examine him and learn what those injuries were. And the nurses taught me a lot. So it was for civilians as well.
That's really interesting.
Yeah, it is. But it really, the traveling you were asking about, New York was my home. And it's great to be back. And we see so many different patients in our practice because so many people do travel here.
San Antonio and New York City are pretty different.
Sure.
But people are the same. Patients don't tend to change too much from place to place.
No, absolutely.
So you were in the Air Force, and then eventually, as most people do, it's time to be out of the Air Force.
Right.
So what did that transition look like for you?
Well, already in the Air Force, I knew that I wanted to study dermatologic surgery. And so I applied and was accepted into a very prestigious fellowship in University of California, San Francisco, where I learned laser dermatology and Mohs micrographic surgery for skin cancer and reconstruction. It was one of my best academic years of my life. Plus, my daughter was born that year in San Francisco. And then we moved back to New York because I had a position that I was hired by the Mount Sinai Medical Center to start their Mohs surgery unit upon my graduation. That was in 1993. You weren't even born.
Sadly, you're wrong. I was almost in college by that point.
All right.
But I'm going to take that as a compliment to my dermatologist. So
yes.
Thank you.
You're welcome. Well deserved.
So Mohs surgery, I think it's unusual to hear that someone is passionate about Mohs surgery, except for maybe, one reason is it's so life-changing for people to be able to help them with that.
Right. It is. It's very important. Skin cancer abounds. Most of us are better these days to use our sunscreen and know to not abuse our sun without protection midday summer sun. But the damage was done 30, 40 years ago, and our immune system can't keep up with that, especially with all the current stresses the immune system goes through, including current sun, other illnesses, mental stress, God forbid someone smoking, et cetera, et cetera. And so skin cancer is so prevalent. And when someone has it on their nose or their eyelid or their lip or their ear, they are very concerned. And I get to see people coming into me who obviously are very anxious, and they leave with a big smile on their face, often feeling that, this was incredibly, and they don't even know how to verbalize that it was an enjoyable day. We have incredible staff. I refer to my nurses as angels, and we get them through it. And most people, I'm talking about 95+%, heal with a really good result. And that to me is the most rewarding thing, to see an anxious person get through it and move on with their life. And cosmetically, we do a lot of things for our patients that are interested in improving photo damage from the sun and the aging process. And what's been great to learn that discipline in fellowship and continue through my career is I've been able to apply that to my Mohs surgical patients as well. So we're not talking about injecting filler in the lips for a Mohs patient, but we can do lots of different lasers on scars to improve them at the right time while they're healing.
It sounds like you're suggesting that there may have been a less aesthetic component to Mohs maybe in the past.
That is an understatement. What Dr. Mohs deserves is just a little background. He was a general surgeon, and in Wisconsin, he was researching how to cure cancer and was using a paste that was applied to the skin to kill the cancer. It also killed the living skin around it. So when the cancer was creating like this ulceration or hole from the paste and would create this significant defect, patients were just allowed to heal on their own. The wounds would heal.
Sorry about the hole.
The wounds would heal.
Yeah.
But then, with World War II, there was a lot of development of plastic surgery for reconstruction. And suddenly that took off like wildfire. So yes, in the mid-70s is when Mohs surgery really got reinvented with what we call the fresh tissue technique, and the turnaround time for the laboratory is not as long, and the reconstruction can be done immediately. But when you have this hole from the paste, You had to let the rest of the skin kind of ulcerate and heal before you could touch it surgically.
When did they stop using the paste?
Not sure. I mean, even in the 70s and 80s, maybe some more senior physicians were still using it, but I would say 60s, 70s.
And what do they use now?
It's fresh surgery. There's no paste. We're just numbing with a little local anesthetic and removing it surgically as it would be removed conventionally, but it's how it's processed in the laboratory because we look at 100% of the margin.
So the surgery isn't done under a microscope itself, is it?
No, it's the tissue that's analyzed under the microscope by the surgeon later after it's processed in that next hour.
So pretty close to real time.
Pretty close, but not intraoperatively.
And are you looking under the microscope or somebody else?
The Mohs surgeon must be the pathologist. Mm-hmm.
Oh, interesting.
It's fascinating.
It is fascinating. I don't want to get stuck there for too long.
Okay.
I've always wondered about this because, I've been looking at the internet in aesthetics for over 20 years, and I remember seeing the photos of the people with the holes.
Yes.
So it really hasn't been that long since this has improved and gotten better.
Correct.
Is that, do you think, because there's a much heavier focus on aesthetics in our culture today?
Absolutely.
Yeah.
In fact, I have to tell you, many years ago when I wanted to make it known that I'm doing cosmetic treatment, and then it's been 50% of my practice from day one, I never thought about posting Mohs reconstructive photos. And one day, and it wasn't that many years ago, the light bulb went off and I started posting on Real Self, as well as my website, reconstructive photos of my patients that I've done. And that gets an incredible draw. People come to me by looking at those photos. Unfortunately, in today's time, there are people who do not see their doctor because they know there's a problem, but they don't want to hear it because they know then that they're going to have surgery and they're going to be scarred or disfigured. So 2-3 years later, when that skin cancer is actually evolved into an open hole, an ulceration, and they're forced to get treatment because of a quality of life, you can't put makeup on a bleeding ulcer, it's much more difficult to do reconstruction to make someone look excellent. So these pictures are bringing in patients at the earlier stage. They don't have to deny.
There are probably a few other factors too, and maybe one might be that people don't know they can choose who does their Mohs surgery. And we want to be able to choose that because we recognize, especially if it's on our face, that there's going to have to be an aesthetic component to that.
Correct.
And the other, I didn't realize until I spoke to another one of your colleagues this morning who you may or may not know, but she said she needed to do Mohs surgery on somebody and their deductible was so high that they decided they weren't going to go forward with it because they couldn't afford the deductible.
It's one of the saddest things that we see.
I'm sure.
Yes.
So let's transition to cosmetic a little bit, and especially laser, because lasers are really exciting. There's so much that can be done now, and you've kind of seen that whole progression from a handful of modalities to where we are today.
Oh, that's very well said. In the early 90s, when I did establish the Dermatologic Surgery Division at Mount Sinai Medical Center, I queried our voluntary faculty as to what need they would have in their patient population to treat unwanted redness of the face, port wine stain birthmarks, red scars, as well as brown spots. And there was enough demand that I was able to acquire the V-beam laser, which is a very common laser we use for rosacea, port wine stains, red scars, and the ruby laser for sunspots, liver spots, brown spots. This took off like wildfire. And at that time, there were only 5 dermatologic Mohs surgeons in the city and very few with lasers. Dr. Roy Geronimus had a very big laser practice, and eventually I joined his practice. So we've seen now in our practice, we have 100 devices. Some of them are duplicate because they're in such constant demand, and we do have 12 physicians that in 5 floors that we have devices, some of the similar ones or the exact same ones on different floors. But, when someone comes with a tattoo, depending on the color, we can choose. And there really has been an incredible advance in laser tattoo removal technology with the shorter picosecond pulse duration lasers that cut down on the number of treatments. We have lasers for, as I said, unwanted brown spots, but also for melasma, the mask of pregnancy, or hyperpigmentation, although that can be very difficult to treat. Wrinkles. Well, what kind of wrinkles? What kind of acne scars? A big part of my practice is acne scar treatment. We have microneedling with radiofrequency. We have several lasers for resurfacing, including fractional carbon dioxide, fractional erbium, totally ablative erbium. What does all this mean? It means that we don't just have to use our hammer, the one hammer we have, and everything looks like a nail. We get to look at the patient, different parts of the face or arms or legs, and determine what's the best wavelength, what's the best laser, and often we're using multiple devices on the same patient.
I visualize your office like the FAO Schwartz of lasers and energy devices. Like there's multiple floors and there's so many.
Yeah, we just don't have big teddy bears.
No teddy bear.
Well, actually, one physician.
The physician is the teddy bear?
Right.
Is it you?
No.
Oh.
I'm not big.
Which one's the teddy bear?
Oh, I can't say.
Okay. Well, if he's listening, he knows who he is, right?
I would think so.
Okay, good. How has this broad view? I think you're probably the only practice in the nation to have that many devices. Is that fair?
No, it's not fair. There are a few. There's a handful. Yes, absolutely.
And are you all collegial with each other? Do you talk to each other?
Oh, absolutely. This is, it's not just how we learn from each other, but as you're embarking upon a newer device, it's really nice to reach out to colleagues who might have used that more than you. And it's amazing how quickly I get a reply from some of my colleagues, whether in Chicago, Florida, West Coast. And it's really a big family, people that just really want our patients in the end to get the best result. That's the end reward.
Now, I want to ask you something that might be maybe a little controversial, maybe not, but I heard about microcoring last week,
yes.
And we did a long episode about Elicor.
Yes.
And I'm curious what your take is on that one.
Well, why would that be controversial, may I ask, before I answer?
Well, doctors often disagree with each other until they figure stuff out.
Right.
So that's the only reason that it might be. But I also find that no matter what I ask, you all already have an answer ready. So
no, I would say that there's big promise with Elicor. Dr. Geronimus has used it extensively in the IRB testing and using it on our private patients going forward. I've been trained in it, and I'm interested in using it. I have treated one of my long-term patients and still awaiting to see the results. I believe that with any device, it takes time. There's a learning curve because you're making improvements yourself to the technique that was taught to you. And that's what I'm in the midst of with Elicor. But I think that I've been impressed that the short term shows virtually no downtime. And that was initially one of my big concerns. But I always have to believe for myself. I really appreciate the representatives of the company coming to me, educating me about the device. And as much as I trust them and their company to tell me what the results have been, I still have to see it for myself, not just in the first week, month, but I have to see it over years. How does that transition to true effects? Is it tightening? Is the tightening lasting? Is it really lifting? Are the lines going away, etc.?
The way I heard the Ellacor described was that instead of injuring the skin, the way that the thermal devices or radiofrequency devices, they all depend on creating an injury to then stimulate healing, was that there is no injury with the Ellacor. It's just removing.
But that is injury.
That's what I thought.
It's not thermal injury, but you are removing. So when you think about getting a vaccination, that little needle prick, it's an injury. It's going into the dermis or muscle or fat, and your body responds to heal. And it responds with collagen production. It may be extremely minute and no one would notice with a vaccination needle, but once needles are larger or the thermal or heat response to a laser is significant to produce collagen, then you start to see improvement, whether it's microcoring or thermal injury.
One of the seats I sit in a lot is how do I translate what I'm reading from the company or what I'm reading from, the highly approved language side of things,
right,
to what is really going on here for the consumer and how do I make it make sense?
But the doctors are going through that too.
Right.
We go to conferences to see new devices, and that's what I'm saying. We have to see it for ourselves. So I reach out to colleagues of mine, and now being in a very big, prestigious laser cosmetic dermatology practice, we are at the forefront. We are involved with a lot of the research for the lasers. And I learn from my colleagues that are more involved with the primary steps of the research than I. But then, as I said, I'm able to reach out to national colleagues as well. That sorts through a lot of the hype, because I've said for many years, I remember the olden days where new treatments had to be practiced for quite a while to see the 1-year follow-ups before they were put into a journal article. And now we're getting things direct to consumer before physicians have a chance to use the devices.
Is that good or bad?
I think that's bad because I have to remain neutral and make sure that my patients get as true a story as possible. And again, I have to believe it for my own eyes. I have to read the science, which I do. I have to believe in it to promote to my patients what I think would be not only good for them effectively, but safe for them.
Can you think of any technologies that you've seen kind of come and go that looked like they were really promising and then fell flat and disappeared?
Yes, I do a lot of body tightening treatment. I mean, it's a passion for mine. And the last several years, there's really been a big push for that. The companies are seeing the market demand. And so I've seen a lot of devices. There is a lot of hype about it, but some years ago, I was actually very enamored with the science of some ultrasound devices to reduce fat. And I was also waiting for that, but it took many, many years for the FDA to approve it. And while they were still waiting, Cool Sculpting evolved. And I started Cool Sculpting at that point and have had a lot of experience with Cool Sculpting. Fortunately, very significant, high patient satisfaction rate. And when the ultrasound treatment did come out, I didn't see the results. I didn't. I had spoken with the lead investigator. I saw the treatment being done. I saw the studies, but I could never get the improvement that was shown to me. And the same thing with certain radiofrequency devices, including massage with radiofrequency. And I did not see the benefit.
Have you ever seen any that you thought might not work that then surprised you? Has that happened too?
Nothing's coming to mind right now, although that might have occurred. If I think of it, I will let you know.
You probably at this point don't really get excited until you start seeing anything happen,
Well, we were very excited when collagenase came out, the enzyme to break up collagen to treat cellulite.
Yes, I remember this.
And unfortunately, there was a lot of bruising. And so I was about to embark upon it, and it took them a while to get on the market because it happened that COVID, the pandemic, evolved right before. So when it did come to market, that's when the bruising potential was noted. And so I never really treated my patients with it. We have had some very good success with Rasonic for cellulite, and we're working with other devices for skin tightening that might improve cellulite, including the soft wave, high intensity ultrasound, and we'll be working with minimally invasive procedures as well. We had initially done work with Selfina for cellulite, and I wasn't happy with continuing the treatment. I just felt there was too much downtime, and there was some hyperpigmentation or darkening in certain individuals from that trauma. But Veli is a relatively new device that I'll be doing.
There's a lot of people excited about that one.
Yes.
And it's pretty simple. It's almost like the entire that cellulite treatment was scaled all the way back to the simplest part.
Yes, I mean, it is minimally invasive. There is some anesthetic involved, local anesthetic injected into the area, and I would expect there's going to be some bruising and swelling. The Rasonic is an acoustic treatment, and we're one of the 16 centers in the country that have been using it from day one. It's not really marketed yet, but it's totally non-invasive, very well tolerated. The discomfort factor is, for the average patient, not more than 2 out of 10. Maybe certain areas might be a little bit more just for that 1 minute per treatment. And we're still trying to perfect that. We're still trying to improve it.
The treatment takes 1 minute?
No, per dimple of cellulite, it's anywhere from 1 to 4 minutes now, and eventually it'll be 1 to 2 minutes.
That sounds promising.
Yes.
So let's come full circle here.
Okay.
And very early in the beginning of this conversation, you mentioned your family, and I'm curious if you could tell us more about them.
Well, I'm blessed to have a really great family. It's my wife is a very bright, knowledgeable woman who tries to keep me younger in my thinking and more socially active to know what's going on in the real world, as I'm at the office for so long and dealing with medicine. And she has really brought up an amazing pair of children. My daughter is 30 and just about to be married in a couple of weeks. And my son is 28 and is an expert angler, fly fisherman, and is a general manager of a high-end fishing resort in Montana.
In Montana?
Yes. So the side benefits are going out there to visit him and see the fruits of his labor while enjoying that beautiful nature and fishing at the same time.
Do they know he's from New York City and they'd still let him in?
They still let him in. Yes.
Do you think he'll stay there forever?
He will stay, I think, in the outdoors environment. He's been back to New York and does well with it, but I don't think that's his passion.
Does his cell phone work out there? Can you still reach him?
Yes.
Oh, good.
Yes. When he picks up, he's probably busier than I am.
It's in the waterproof pouch, and it's hard to answer.
Yes.
Yeah. When's the next time you're going to go out there to see him?
Probably August or September.
It's beautiful. It's not very warm, though.
At that time, no.
Not ever. Pretty much all year, it's not warm in Montana. When patients come to see you for the first time, what can they expect from that visit?
A healthy amount of conversation after listening to them. I really want to hear from them what's bothering them, what they want to see improved. Often I pass them a mirror so they can, as I say, take me on a tour of your face, tell me what bothers you. And then we candidly go through different alternatives and tell them what I think does work. And there are a fair number of patients that come to me that should not have treatment for what they're interested because there's too high a risk that it won't be effective enough to make them see improvement. I don't want them wasting money. I don't want them doing something because they saw it on Instagram or direct to consumer if I don't think that it's going to work on them for their particular indication. So we talk about what does work and the reality of this may take a few laser treatments. This may take several syringes of filler. If your budget is of X amount, I'm not just going to put in one syringe to fulfill that budget if it's not going to do anything. I'd rather you not waste that money. When certain individuals come to me and they want Botox and fillers and a laser or radio frequency to tighten their face, but they could spend an incredible number of thousands of dollars to do all that, and in the end, their sagging is so much that they are a true facelift candidate, I'm going to tell them, save all that money that they would have spent with me and use it as a down payment towards their facelift. There are other people that can't have a facelift. Surgically, medically, they can't undergo that surgery. And then we can do those things. Mm-hmm. But certainly the patient will come in, and when they leave, I hope that they will be leaving with a healthy amount of information that they understand, and we give them a line item quote sheet so they know what those finances are ahead of schedule.
So transparency is important to you.
Very important. Education, for me to comprehend what the patient is interested in, and the communication is all very important.
Is it relatively easy to get in to see you, or?
Within a few weeks, often, not more than a month.
And then are there things that you don't do that other people in your practice take care of?
I don't practice any general dermatology, acne, psoriasis, warts, or skin checks and biopsies for skin cancer. My most surgical patients come to me with biopsy in hand, having been done by their referring doctor.
But you do all the injectables, lasers, and all of those things yourself?
Yeah, so that is 50% of my practice.
How do you think about injecting these days?
Well, I do it every day. The fillers are really a solid part of the practice. The hyaluronic acid fillers are so much better than the old collagen fillers we had from cowhide. And what's nice is that they're a natural substance. We all have hyaluronic acid in our dermis, and this is synthetically made in the laboratory. And there's an enzyme to dissolve it if we don't like the result, which does happen. I, do see on my own work occasionally where either the patient has absorbed more water in that filler, because that's how many fillers work, and we can reduce it just gradually, which is very nice.
Do you see people who've had filler elsewhere and it's gone wrong and they come to you to fix it?
Yes.
Yeah.
Mm-hmm.
Do you remember when you reminded me that there was a filler, I can't remember which one, where you had to have a patch test to get it?
Right. That was one of the cowhide fillers, right? The Zyderm, Zyplast.
Come back in 6 weeks.
Yeah, we were doing 2 tests. We would do one, I can't remember, it was on the forearm, and then maybe the other was on the face, but they had it theoretically after 2 tests. If they were negative, then they only had like a 1.5% of becoming allergic to it.
I wonder why that one didn't make it.
Yeah, but that is where the basic evidence of science came from for fillers. It was really fascinating.
And I'm sure it got us where we are today, but I'm glad that we're past it.
I'm glad we're beyond it. And the fillers today last at least double the time of those.
So before we wrap it up, I want to ask you what you like to do outside of work.
Well, I'm a gym rat, so I do like to exercise and stay fit. I love nature, and I love learning language. I'm just not good at it. So it forces me to be on Netflix watching a foreign language with the foreign subtitles, and I'm trying to improve myself.
What language are you learning?
Trying to learn French for about 4 decades.
Oh, no.
One of my passions had been certainly to take a year off between college and med school and go to France and even study in a cooking school or et cetera. And, a side passion has been, or dream to, live within that country for a month or so. But I'm too conservative and I have obligations, at least that I make for myself, and I can't take myself away from family and practice to do that.
Well, I hope you get a chance someday.
Well, thank you.
Certainly. There's a lot going on, and you're very busy, and I think it's remarkable what you're doing for your patients.
Well, I'm very appreciative that I have the patients who come to me, and I really respect them. I know it's hard to make the decisions as to whom to see. So when they come through my door, I'm the one that feels privileged.
I've often thought the biggest barrier with dermatology in particular is realizing when it's time to stop solving problems on our own and go get help.
Well, that's, I think, one of the best things about the internet, and specifically even Real Self, because what I've loved from the website, how many years ago did Real Self
2007.
evolve? 2007. So for 16 years, I've been a participant because it really was a fantastic medium for patients to go online, learn about procedures, learn about conditions, and hear from other patients what they've been through.
Mm-hmm.
So one of the great things that I experience consistently are my educated patients. And virtually all nowadays are educated about their condition. So they're asking questions. And as we have this communication, it's really meaningful. What I'm saying is not going over their head. And they're very insightful. And it really helps me target as to what we should be doing on them.
I think we could extend our old, the way we knew that we were successful was when patients would come in and say, I feel like I already know you. And I think you're adding to that a really nice new piece, which is, and I know why I'm here.
And I've gone many times, I'm so glad to finally meet you. I've seen, your videos on Real Self, and I've read your answers. I never want to consider myself a celebrity because, first of all, I never will be and never wanted fame. But it's nice that they have that validating factor. They can really feel comfortable because they're not referred by a doctor. They're referred by the public.
It's nice to hear you say that. That was our mission all along. So.
Well, it worked.
Thank you so much.
You're welcome, Ava. I really appreciated being here and having our discussion.
If someone is interested in finding out more about you, where should they go?
They can go to realself.com or just Dr. Ron Shelton on Google. We're on 34th Street between 1st and 2nd Avenue in New York City, Manhattan.
Thank you for sharing so much of yourself with us today.
You're so welcome. Real pleasure to be here, as I said. Thank you.
If you're considering making an appointment or are on your way to meet this doctor, be sure to let them know you heard them on the Meet the Doctor podcast. Check the show notes for links, including the doctor's website and Instagram, to learn more. Are you a doctor or do you know a doctor who'd like to be on the Meet the Doctor podcast? Book your free recording session at meetthedoctorpodcast.com. Meet the Doctor is made with love in Austin, Texas, and is a production of The Axis, TheAxis.io.